First, we want to go through the term list here. And then we had another few things, right, that we wanted to talk about. We wanted to talk about the assignments. If it comes to the assignments, to make sure that you color and you label. And if you don't do one of them and you get an assignment kicked back, you look at the rubric and you say, oh, I didn't color it, that's why I didn't get the points. And so it's almost like it's a completion question points. So we look at what you're doing and we're grading it from that perspective in terms of the point values. So we're looking at you did all the terms, you label all the stuff, you answer all the questions, and you colored all the things. If you did all those things, then you get points. If you don't color, you don't get those points. All right, and I do the color on purpose because it slows us down with these terminologies, which is very important. And then the other thing is the Padlet. I can only give you, or we can only give you, Sonia. You've all met Sonia by now, right? Good. If you're tutoring, Sonia, any questions, you feel like you can't talk to me because I'm like, you know, whatever the teacher or so, Sonia, everything is like, she's like, take care of you. But the Padlet, we can only grade you if you have a name in it. And so make sure, if you don't sign in, if you go into the module Padlet, that last thing on each module we do is the Padlet, the questions and the tips. If you go in there, you can go to an external site and then you can sign in, an external window. If you're signed in, then your name shows up. If you're not signed in, your name doesn't show up. So you have to type it in. So I want to make sure you do that. If you show up anonymous, we have to say, hey, we don't know who you are. Please tell us who you are. But so far, nobody really responds back. So make sure if you don't get points in that, as easy as you can be, you go to the grades, you see like, hey, I didn't get points for that. Why didn't I get points for that? You shoot us a text, or you go into Padlet and say like, well, my name don't show up, so guess what? They don't know who it is. You give them some that, and then we give you the points. So make sure with those little things, I know it's a lot of little here's and there's, but they all give you points. Make sure you collect all those points. All right, it's not just all the tests. The tests at the end of the day, or the tests at the end of the day are third. And everything else is most likely busy work. So don't lose your points doing the busy work, just because we didn't go back. So we're trying to catch it, but you also are you're responsible for your own grade. So you make sure you catch those things too. The grade number, the percentage in Canvas goes up and down a little bit. It's a little hard to catch what's what sometimes, or if a deadline goes down, then all of a sudden the thing drops for a moment because we're maybe late for a few days, and all of a sudden we have a 0 point on something. And so if you do all the assignments, you're good. So your job is to do all the assignments. The percentage in Canvas, at the end, we put in the grade. So it's between you and I who's going to do what we're going to get. So Canvas doesn't have nothing to say. So that's just an indicator of what we're going on. All right? So make sure you keep that in mind too. Because it freaks me out. I'm taking a class right now, nutrition. I'm like, oh my God, my grade is below 90. I'm like, what's going on with me? So don't feel bad about reaching out if something's happening. School can be tough that way. But I got you back. If you do all the assignments, we got you back. We're not here to punish you. We're here to teach you. And the assignments, if you get 5 out of 10, you resubmit. You fix your mistakes. You fix what you didn't do. You resubmit it. You get all the points. All right? Just don't wait till the end to do that. Then I'm going to go like, really? You had to wait till the end like everybody else? And I got like a zillion of them now? Then we're like, I got to put in these grades. So just work with us, all right? And then we're all good. So you check your grades and we check your grades. All right, so what I want to do now is I want to go through the skull, and again, like last week, but a little bit more. You've already done more of it now, so we understand it better. Facial muscles again, and then we're going to start with the spinal column and the rib. So basically the axial skeleton. If you look at the skeleton as a whole, we have an axial skeleton, which is the blue stuff here, and we got an appendicular skeleton, which is kind of more the brown stuff here. So the axial skeleton is like the midline, the axis of the body. That's the axial skeleton. and that is the vertebral column, the brain, the skull, the hyoid bone, that's fine, and then the thorax, the rib cage, and the breastbone. All of that in the midline is the axial skeleton. And then the shoulder blade is the clavicle, the collarbone, to the outside the arm. That's appendicular skeleton. That's the appendages that are attached to the axial skeleton. And down here we have the hip bone, and then the legs go out from the hip bone, and those are also appendicular skeletons. So you got them like here. So that's what we're doing. So today we are basically covering the entire axial skeleton and all those little landmarks I want you to know on those. Yes, Sonia? Okay, good. Yeah, make sure everybody interrupt me if something is not clear or anything like that, because I can get all nerdy on this stuff and a little bit cuckoo sometimes. So when we go to that list. You guys got that term list? Make sure you have a term list. You don't have a term list, we got term lists. Don't worry, we got term lists. Make sure you have one of those term lists. So if you don't, and you are watching the video, on your canvas, on the test review, you got that term list there. And that's all the terms that I want you to know for the second test. So be really clear. On the second test, nothing other than these terms are going to be on it. So don't go looking for like, oh my God, that looks like it could be, and then you go Googling it because it's open book. You can Google, that's cool. But they go like, oh, well, it's this hole there. Maybe it's not quite clear. Maybe I don't know. Look at the list. If it's on the list, it's on the term. It's on the test. If not, it's not on the test. All right? Be very, very clear about that. You save yourself a lot of grief. Because one of the things, anatomy's got a lot of stuff. I give you, what we're doing today, we can give you 1,000 terms. And I don't know all these terms. I'm going to forget. We're all going to forget. And it's like it's a building thing. It's an onion layer thing. You don't need to know all of those terms to know anatomy. You can look the stuff up. That's why they made picture books. The anatomy atlases. There's really good stuff out there like that. Well, what we need to try to do is create a framework and something that we can start talking about it. And then we can take the knowledge we have, that framework, and a lot of us go into nursing, right? So then we get into nursing, and then we see what goes wrong, and we learn what goes wrong. And so that's why we're starting to build a framework with it. So that's why I'm not wanting to study too many terms. I want you to understand the ones that we are doing, and the muscles and so forth, okay? And I can tell you the stuff that I teach you here in terms of anatomy, terminology, and all of that, that gets you far clinically, because I work clinically every week, and I have very, very interesting patients. And, a lot of that stuff is covered with what we're learning here. My patients they're musculoskeletal, they're pain patients. They're like chronic pain or enhancement of performance, musculoskeletal stuff. But we're going quite deep at the end of the day, actually, if you go really when it comes to an application perspective, but not just a scholastic perspective. Any questions? No? So the first one we have is the frontal bone in the skull. So that's the front of the head. So when you have a skull, oh wait, where's my skull? I have a skull. Well, I got a skull right here. When you have a skull here, I will need a skull from the back table over there. Okay, when you have a skull here, the frontal bone is the one that's in the front of your head. That's a nice name. And so when you walk into the wall, you walk in the wall with your front. That's the frontal bone. So that's not too hard to understand. Thank you so much. And then we have a few, if you look at your list, underneath that first term, frontal bone, you got a couple of terms that are tapped in one, right? You see there, superciliary arches and glabella. And the superciliary arches are the eyebrows right next to, the superciliary arches are the eyebrow parts of the bone right above the eye. So if you look at your skull, or actually you feel in your own head, you feel like there's like a ridge. There's a ridge right before you go into the eyeball. Don't poke too hard, that hurts. But right in front of it, you've got a little ridge where the eyebrows are, or used to be. That's known as the superciliary arches. So if I put a label here on a test, And I say, what's that thing called? You look on your list and you say, oh, that's a superciliary arches. Or actually say, what's this landmark called? All right. And I use these models here that are on your table, and on the test we have pictures and we have videos of these models. And I also do have these models as pictures in the test review. The third tab, there is a whole list of like, I don't know, 18 pages or something with pictures of these models, which are great for you guys. Just look at them. Don't, print them out. Yeah, you can print them out. It just takes a lot of ink. But just look at them when you watch the videos or when you do the labeling or you figure out what term is what, because it's the models that I use on the test are those models. So you have the most congruent kind of model. Anatomy is not like mathematics. It's fairly accurate and fairly congruent with one another, but there is diversity with it, and so we have to keep that in mind. So sometimes on your picture, it might not look exactly where it is or what is exactly looking like that, but I want you to deduce and do the best that you can and indicate that, because again, it's not an exact science. So part I want you to be exposed to that incongruency a little bit, because we need to be aware and learn that part, because that's part of what it is. So on your labeling exercises, the other thing on the labeling exercises that I want to make sure all the time is there is labels, but please, if you read at the instruction, it says ignore those labels. Just do the ones on the list. So I only want you to indicate the terms on the list. When I get these pictures from Google and all that, everybody has a little bit of a different understanding what we should label and so forth. And so that's why there is that problem. And you only have to label each term one time on the lab exercise. So you don't have to label the pictures more than once when it comes to the exercises. You've done the skull so far, so most of you have done really well with that, so I'm totally happy with that. So the glabella is the next term. The glabella is a term that's in between the superciliary arches. It's known as the hairless. It's known as hairless, and that's in between the eyebrows. So that's right here. And so that's the glabella. That's the second landmark that we need to know from the frontal bone. And then as we get to the parietal bone, we get to the side of the skull. Oops. We have the front here, and then we go backwards, and on the side, we have each side, we have a parietal bone there. So that's the side here. So that's the skull, as we've noticed here, are made out of different plates, bone plates. So when we look at the skull from the outside, we think like that's one bone. We just look at a head. But as we learn now in the lecture already and now in lab, we learn that these are not just one bone. There's multiple bones that make up the skull. And when you look from bone to bone, another chapter this week we have is joints. And a connection between two bones is a joint. And some joints are freely movable joints, like your elbow joints or your finger joints. But other joints, they don't move too well. They are just two connections between bone and bone. They move maybe a little bit. And those are joints, for example, we have in the skull. Those are the suture joints. And they're very often jagged. You see these jagged lines in here. They're jagged together. They do move a little bit because they have found tissue in them that's actually not osseous, not bony tissue, that's mobile tissue. So they move very, very slightly, and that comes into play when somebody has a concussion, because the skull plates move very slightly amongst one another to create sort of a breathing dynamic with expansion and contraction that then has something to do with the inside fluid that surrounds the brain and feeds the brain with nutrients. And so that becomes very, very important. All right, that sort of discussion. Then we get into these sort of subtle sciences. But for us, what I want us to know, sort of as a representative of these jagged lines, is the sagittal suture, and that's the one that's between the two parietal bones. You see that sagittal suture right here, between the two parietal bones. That's the one I want you to know there. So that's right up here. Yeah, there's some cool stuff. If you have had a concussion, you probably know what we're talking about when his brain don't work right, when you hit your head real bad. So from there, then, what I want to do, and then the fontanelles. We really don't have fontanelles on the list, but when we look at these connection plates in skulls that are just baby skulls, that are fresh, that are born, they're not formed yet. So these plates, these skull plates, are being formed right now. And what happens in the ossification process of the flat bones is we have a membrane, and the bone forms in between the membrane. And so the fontanelles are sort of these parts where we have the membrane is left, but the bone is not formed yet. And so that's why we don't pull the finger down there. So that's why we're very gentle with those when they're born. And that's very important because the skull is a big thing. When you've got the skull needs to be born, it needs to be able to be squeezed to the birth canal. It's too big otherwise. All right, so we have to have that thing not be fully formed. So that's where the fontanelles come in. From there, I want to move to the occipital bone. And you go down your list. The occipital bone is the green one here, is the back of the head. So if you touch the back of the head, that's your occipital bone. If you feel, when you look at some landmarks that we have, a few more landmarks, one of them is a big bump on the back of the head. It's a big bumpy on the back of the head. That's the external occipital protuberance. If you look at your list, it's on 2 lines. Make sure you see that. External occipital protuberance, it's on 2 lines. It's a long word. And with long words, what we do, we have abbreviations in anatomy and probably everywhere else too. So we call that an EOP. So if that comes up in your test, you can say EOP. All right? I know what you mean by that. Then, you know. If you take that the second test, one of the things you have to be aware of you have to spell these words. And so that's why I got this term list. It's very specific. You copy the term over as much as you can. But if you got spelling errors, the program will say it's false. And then I go back in the background and say, like, no, that was fine. And so when you get the test done first, I don't know if you have other classes, it's like you finish the test. It's like, oh my God, I only got 10 out of 50. And so don't freak out. You know, I go back and look at all of that, and everybody gets more points. For sure they get more points, they never get less points. But just be aware of that. So misspellings in those kind of tests where you have to fill in the blanks, the program might say, oh my God, it's wrong. But then we go back and look at it. It might take a couple days because we got a lot of tests coming in. But I know myself, I'm like, oh, I freak out. So I want to make sure I tell you all the time, as much as I can. Don't freak out. Give it a few days, and then we'll figure out what that meant. All right, so be aware of that. But that comes in because that's a hard word to spell. So that's why it's like, go for EOP if that comes up on the test. So the occipital bone is in the back of the skull, and that reaches underneath the skull. And underneath the skull, there is a big hole right in here. Right in here. Right in there. And that's where the brain goes up and down. In here is a brain. That's a brain. The brain needs to be really protected because it's very, very wobbly and mushy and jello structure or spaghetti. Not al dente, like mushy spaghetti. And the brain goes down here. So that's actually the reason why the brain has a skull around it. So it's well protected from the environment. Because if you bang into the brain, that's not cool. That bruise is really easy because it's very, very plastic, very moldable. Because you've got to be able, I mean, think about it, you've got to be able to make a flashcard out of these terms and study them a few times, and then your brain remembers it. That's really hard stuff to do. And so the brain needs to be able to grow extensions. Each neuron, nerve cell, has to be able to talk to other nerve cell that we remember all of that stuff. And so that sort of requires, in some ways, that structure and function question for the brain to be quite of plastic. We call it plastic, like, moldable and very soft and not hard tissue. So that's why we have a skull around it. And so what comes out of here is really the brain stem. I mean, you remember the Superman guy, Christopher Reeves, the first Superman actor, and he got a horse accident, and he got clipped here, and he couldn't breathe anymore. And he got clipped at C2, which is down here, right here at this second vertebra. And his breathing center was impacted. The breathing center is part of the brain stem. It's part of the brain. So that there is a clinical example of how the stuff reaches down. All right, so that's one part why the upper cervical area is very gentle, very important. We want to be very tender with it. And that hole has a name, of course, and that name is the Foramen Magnum. And foramen, whenever you see the word foramen, it's like you want to make a list. You want to make a list with common names that we use as landmarky type things, and like on the bone. And actually, Marriott has some lists. I gotta find them again in the book. There's some lists of that. There's some lists if you Google it. I just haven't done it lately. And the word foramen is always a hole that something goes in and out. What goes in and out of the hole in these bony things? Mostly nerves, arteries, or veins. Tube things go in and out of the hole. So that's one of those terms that comes back over and over, foramen. Magnum is just big. It's the biggest hole there is in the skull. That's why we actually study it. And I don't study all the other holes. There's just so many. It's just not enough time to do everything. All right, so that's the, and then next to the hole, we got to consider this skull needs to be sitting on the rest of the body somehow. And it does that by having a joint from here, right next to the big hole, with the outside of the first vertebra, and it's sort of a wobbly head that sits on these two bumps here. So you're sitting like, there's two bumps here, one on each side, and so the skull sort of sits on here like a wobble head. That's why, good posture is important, because if your head is over your shoulder, it's kind of the bubble head, and you don't need all these muscles to contract really hard. When your head is down like that, it's really hard to keep that thing up, but these muscles have to contract really hard, because you're not balancing up on here. And so those structures are known as occipital condyles. Those two structures next to the foramen magnum that make a joint with the first cervical vertebra. The term condyle is another one, like foramen, pretty much that always makes a joint. So if you see the word condyle, you think another bone connects with it. You think joint. In the old days, I remember in the old days when you wanted to study medicine, you had to first study Latin because of all that stuff. And so we just did the short version of it. We're like, this means that, this means that, this means that. I never studied Latin. Hell no. I couldn't handle that, I don't think. Or maybe it couldn't handle me. All right, so when we go from the occipital bone, we go further down, we go to the temporal bone. And the temporal bone has multiple structures associated with it. Well, look at the bone. It's kind of a complicated looking bone. It's got this thing coming out. It's got these holes here. It's jaggedy looking. It's the bone right where the ear is. So it's right here behind the ear. That's that bone. So it is a very important bone. Temporal bone, right here on the side. So one of the structures that we want to know is the hole right here on the outside. That's the ear canal. That's that thing you stick you shouldn't, but you do sometimes, stick your finger in. Or the kids do at least. That's known as the external acoustic meatus. External acoustic meatus. Yeah, it says acoustic. Meatus is another word. When you see the word meatus, you're thinking of a hole. Like foramen, another hole. Or canal. Meatus can also mean canal. Because actually sometimes in anatomy books you're going to see the same term and it says external acoustic canal. Or even external auditory canal. Auditory is hearing, right? Canal, meatus. I actually prefer the word canal from meatus, but it's old language. So we have to sort of work with it. So one of the things with anatomy that when I went through Cairo and it was like chiropractic, it's like you really go detail. It's like which one is what? And there's all these AKAs, all these also known as. different sound, you know, and you wonder if it's the same or not the same. You don't want to be wrong and sort of those things. So that's another problem with anatomy. So make sure you're at least aware of it, that like if it comes up as a question, you're looking it up and don't question yourself too long. So like extra-acoustic meatus has a whole bunch of terms that mean the same thing. So we just got that one. I think I do put in a test a few other spellings, so just do me a favor and use the spelling on the list as much as you can. That caught style on my having to go grade it afterwards. So that's that hole here, right here. And then when we go forward from that hole, we have this bar that goes into the cheekbone. And that bar there, actually that bar, I don't even mention that bar there anymore, so never mind about that bar. That goes into the cheekbone here. If we go to the back, we're going to talk about that bar when we talk about the cheekbone. I'm going to make sure you study that. And when we go back from the hole, we're going to touch a bump in the back. And that bump, when you push on it hard, it can be a little tender. Push on yours. It can be a little tender. It's kind of an interesting kind of bone. It's actually where we get meningitis from, that bone, from behind the ear. It's the Mastoid process. And it's a bone that has air pockets in it. So it's an interesting one. It is a little tender. And then right in front of it, underneath it, it's really hard on a living skull to see it, but it is there. Like totally underneath here, you got a little pokey thing coming out. It's known as the Styloid Process. And you all know Styloid Process from the, you know, the styloid on the pen thing for the iPad and the phones and all that. Stylus means pen. It's the same thing. And process, one of the reasons why I put that in here is the word process. Process means something sticking out from a bone. And very often, or most likely actually, when something sticks out from a bone, it means it's a muscle attachment. So a process is most likely a muscle attachment. The mastoid process back here has these muscles attached that go to the front actually, right in here. And they go down here, they move the head around like that, kind of moving the head around. So that's a process we talked about. The styloid process, that little pokey thing here in the front, that's deep, deep inside, has muscles attached that go to the tongue and to the bone in the front here, the hyoid bone, and moves the tongue and the bone up and down when we swallow. So it helps with that. So it's another muscle attachment. So, you know, you always have to kind of ask yourself with these anatomy things, is like, why? You got to be like the 2-year-old kid. Why is this like that? Why is this like that? You know, why does the world like that work? Because there is always a reason. In anatomy and physiology, in the body function, there is a reason why is it like that. It's like, why is there a thing sticking out like that? If there's no point in having it, that wouldn't be there. There's no point in having that. So there's probably going to be a muscle attachment. So things stick, bony prominences sticking out, probably a muscle attachment. And then the muscle can attach to it and move things around. Muscles move things around. So a lot of what you're learning with me in terms of bony attachments are bony prominences and landmarks are muscle attachments. Because, you know, I'm a chiropractor, so I like bones and muscles a lot. I do a lot of body work, so that's like my jam. So if you have any questions about that stuff, don't worry, ask me. I try to be good with that. So that's the temporal bone. What else we got in the temporal bone? We got the mastoid process, we got the extra-acoustic meatus. We got what we haven't touched yet is the mastoid mandibular fossa. So if you look at this, look at this one here, where you have the jawbone attached. You have the jawbone here, and you have the temporal bone here, and you have an area where they connect with each other. And the shallow depression on the temporal bone that receives another condyle, which we already had here by the skull, underneath that condyle, this is going to be called the condyle. That shallow depression is known as the mandibular fossa. So a fossa is sort of, a shallow depression that you make a joint with. Very, very often a fossa creates a joint. Sometimes, let's stick with sometimes muscle attachment, like this is a fossa too because it's a shallow depression and muscle attachment. But most of the time it's a joint making thing. So it's a shallow depression. Because if you look down the list, let's just go down the list that way. Let me see, I forgot the petrous portion, we'll go that to that. Go down the list to the mandible. See down there the mandible? Mandible is this bone here, the lower jawbone. And the mandible has this thing in the back, and we're going to cover the mandible again at the end, but the mandible has this thing in the end sticking up, like right here, that goes in by underneath the ear, that makes a joint with that bone here. And that's known as the mandibular condyle. You see that on the list? Mandibular condyle. So the mandibular condyle is the part of that jawbone that goes into the mandibular fossa, and those two make a joint together. Joints are complicated because if you think about bones, bone is like hard, brittly stuff. I mean, this is plastic, but still. And if you have bone on bone, it's like you have two bricks grinding on each other. That's really painful. Just ask somebody who has no cartilage left in their knee. It can be very, very painful. And so joints become a really important thing. So you have cartilage in joints. I don't know if you haven't bitten on cartilage. That's kind of weird stuff to, weird structures like upperwear material. So you got cartilage in there that like protect the bones and make it smooth motiony. So it gets very complicated. This joint is very, very complicated because you got one on each side. They have to both move the same way. If one moves different than the other, that hurts. That's called, people call that TMJ. The TMJ disorders problems. I don't know if you have had, teeth grinding and stuff like that. That can be very painful. So that's what happens right in here. So that's kind of an interesting place. So then let's go back to the temporal bone. And if we do the last term there, if we open the skull plate up, like right there, we got a ridge right here. You take the outer ear hole, the external acoustic meatus go inward, and there's a ridge right there on the inside. You see that ridge? You can open the skull on your chest too. Get tactile here. Part of why we do these labs is so we have some tactile experiences. And believe me, I'm so grateful you guys are here. It's so much fun to be back in class. Do you prefer class or online? In class, right? Yeah. Well, hopefully we do a combo. I have a hard time with sticking up to assignments on the online. You guys have that problem too? I'm like, I always miss assignments on online. It's like, no, where's my person telling me what to do? Anyway. Anyway, this ridge here on the side is known as the petrous portion. Petrous portion. See that here? And that portion is just a part. And what's really cool about this is we're going to learn that in neurology, when we talk about the brain stuff. This is where our hearing apparatus is in. So in here is that little snail that takes the sound waves and makes sure we hear. And our brain knows that he has spoken. That's out here, all in here. So we're going to learn about that. So that's the petrous portion of the temporal bone. Cool stuff. And then from there, now we get to the really complicated ones. Now we get to the sphenoid bone. And the sphenoid bone is one you don't really see much from the outside. The sphenoid bone is a bone that goes across the skull. It like pierces right through it, behind the eyeballs. And when you open the skull, you see a little landmark that you see that's part of that bone that goes across, like from here to here. Like this picture here shows it like this. This is the bone, right, from here to here. But there's one piece in the middle where you can put your finger in. That thing here, that's what I want you to know from there. That's the sella turcica, a Turkish saddle. And that's a bony indentation The interesting thing about that thing is it houses the pituitary gland. The sella turcica houses the pituitary gland. And gland tissue is like epithelial tissue, like we studied that in chapter 4. It's like very fast growing, like the skin. Grows very fast. And brain tissue doesn't grow at all. I mean, it does a little bit, but very, very little. And it's very soft. And so one of the dangers would be, if you have a gland, how dumb is that? You put one of those fast-growing tissues right in the middle of this soft brain, and if that gland grows out of hand, it's going to push into the brain and cause all kind of havoc. So what are we going to do about that? And why the heck do we put a gland into that brain? Well, for once, we have to put that gland there because the brain has a connection to the rest of the body via the gland. So the brain, what we think, what we feel, how things are, influences how our body functions. Maybe you ever heard before of called psychosomatic illness, for example. So there's a connection between brain and body. And so this gland right in here is connected with the brain and connects the brain to the hormonal system of the body. So it's very important to actually have that there. But in order for it not to cause havoc, if it grows out of hand, we're going to put it right and enclose it in the bone. And so that's what we did. And so that's what we have in the sella turcica, is a gland sitting into the brain. And it's in the sphenoid bone. The other reason, and I had a colleague, a student friend of mine, and his brother had a tumor that grew here, and it pushed through it, and it pushed onto the brain, and then the person could only see like a little sliver, and all the outside periphery you couldn't see anymore. Tunnel vision. So there's some clinical implications about that. So it can be pretty interesting. So that's the sella turcica. The term means Turkish saddle because it has these 4 bones sticking out, and that looks like a Turkish saddle. And so that's where that visual comes in after a lot of wine and a lot of being in old Rome at that time or something like that. The other reason why I like the sphenoid bone is all the other bones are attached to it, and if we have a concussion or something like that, we can work with that bone clinically, like craniosacral therapy or something like that. Or I have a technique where I can put a balloon on a blood pressure thing and put it up like a finger cut and put it up here and pump it up and move that bone a little bit. And we can release concussion problems that way. So that's clinically where that becomes an interesting application if some of you are massage therapists or something like that. But other than that, complicated. It's not complicated, it's just because it's deep inside. We can't really touch it. That's why it's a little occultish. But the other one that's a little bit like that is the ethmoid bone. And the ethmoid bone is literally deep in the nose. It's the deep bone in the nose. So you take the skull here, and you got these 2 sliver bones on top. These are called natal bones. You're looking down on your list. See that? It's called, the last term on that skull terms, it says nasal bone. So that's these ones on top here. But if you take these off, inside deep, you have what we call the ethmoid bone. One of the big structures there is this long thing going up and down, and that separates the nose from right to left. And if you have one that's not quite straight, is crooked a little bit, and your breathing is all, you know about it. Because it can be a problem. So it's a very important structure. But the top end of that structure sticks up right here through the skull. And it's known as the crista galli. So that's a cool term. I like that term. So it's like it sticks up in the skull. You can feel it. Take off your skull there. You feel it in top. It's like a little thing sticking up. And it actually a membrane attaches here, then goes around and separates the brain from left to right. And if you had an name before, it's called a falx cerebri. We'll talk about that later on. So that crista galli. And around that thing, this is like that here from the above down picture. Around that crista galli, we got these areas where we have these holes. And these holes are for nerves that come from the upper nose into the brain and make you sense smell. So the smell nerves go through these holes. and that is called the cribriform plate. That's on that list, I think. Cribriform plate. Cristagalli and cribriform plate. Good. So those are those sort of two more or less a little occult bones in there. And then from there, and again, if you have questions, just reach out, ask, okay? From there, we go to the maxilla. So we're leaving the skull bones proper. We go to the facial bone. So we have some bones that are mostly associated with the facial features, and also, of course, with eating them is the jaw, right? So we go from the maxilla, which is the upper jawbone, and then we have a mandible, which is the lower jawbone also. So we have these two rows of teeth coming together so we can chew. And that will help us break down food, that's digestion right there. We'll talk about that later on in the semester with all these little different names and all that. But what I want you to know about the maxilla is the roof of the mouth as a term, as a landmark. Again, there's many landmarks, but that's one I want you to know. The roof of the mouth on the maxilla is known as the Palatine Process. See the Palatine Process of the maxilla. And then if we actually reach further back on that roof of the mouth, to the back, we have a bone itself, and that's known as the Palatine Bone. And that's also on your list. Let's look at that again. See here, you have the roof of the mouth, and if you go further back behind the teeth, you have its own bone. And that's the Palatine Bone. Palatine Process, Palatine Bone. And no, I kind of use that as a sort of a place where I show you it's really intricate. You know, things get really small. And then Palatine Bone, after that we get into we did the nasal bone already. What we can do is the Zygomatic Bone. See there on the list? You jump over the mandible, you get to the Zygomatic Bone. And the Zygomatic Bone is your cheekbone. Your cheekbone. So that's the Zygomatic Bone. Cheekbone. Important muscle attachment. I focus on what I want. My sort of focus on bony stuff is muscle attachment. All right, there's so much, you know. So Zygomatic Bone is that, and then we have the mandible, and the mandible is the lower jaw bone. We have a few things that come with the mandible. For once, we have a big structure in the front, like the front part. We call that the body of the mandible. The body of the mandible. And then we got another part on the side, the side bar, and that's known as the ramus of the mandible. And then we already talked about the back area that makes a joint with the mandibular fossa of the temporal bone, and that's the mandibular condyle right here. And then another interesting structure here that is, when you open it, you see this thing here, this sharp thing sticking up. And that's known as the Coronoids Process. Here, no, Coronoid Process. Here we go. Why didn't I underline that? Oh, here I did. There you go. Coronoid Process. There we go. I know, it took me a long time to underline all these things. That way I don't have to look so long for them. All right, and I think that's it for the terms, in terms of what I want you to know for the skull and the facial bone. So far, so good? So what I think we should do is I want you to go to the tables and go through the list with your classmates on the table and talk about them. And if you haven't done the homework yet, finish doing that. And we give you about, I don't know, 20 minutes or so, and then we'll do facial muscles, and then we'll do the spine after that. All right? All right, good. I want to hear some chatter. All right, so let's go to the facial muscles again. And we got a model here. This model right here for that. Oh, just missed that probably. And when you look at your term list, reading again? No, there. Your term list, it's on the third column. You see there it says muscles. Right underneath the muscles, you got a list of a few of them. Those are the facial muscles. So we're going to go through them, and then you're going to do that on the desk. The first one on that list is the Frontalis muscle. And the frontalis muscle is an easy one to remember because it's right over the frontal bone. It's the front of the head. On here, it's right here, this thing going up and down. All right, so that's not too hard to remember that. The second one gets a little more tricky. It's the corrugator superciliary muscle. And so one of the things, the facial muscles, the names are, you know, first when you study anatomy, it's like, oh my gosh, these names are crazy. But then you just take a step back and go like, it's kind of cool, these names. Who came up with this kind of stuff? You know, it's like superciliary, corrugator. So these names, you just got to appreciate them a little bit. And, you know, anyway, that's, a lot of them are telling. This one is not really telling me that much. That muscle is right here above the glabella. And the reason why I put that muscle up is because it's the frowning muscle. Makes you look angry. And it's the one that they put Botox in. You know, if you don't like to feel angry anymore, you put Botox in. And then your anger motion goes away. No, wait, the muscle don't contract. The anger might still be there. On this one, you don't really see it that much. You see a little bit of up and down stuff. So that's the corrugator superciliary. And then we got a couple muscles that are round. We have one around the eye, and then we got one around the mouth. The one around the eye is known as the orbicularis oculi muscle. Orbicularis is the orb, is a round thing. So orbicularis, you're thinking, oh, sounds round to me. Okay, something round. So you want to work with association as much as you can with this stuff. And muscle names, sometimes they're named by their shape, how they're shaped. This is one of those examples. All right, muscle shape, and then where it is at. And so then we have one more, an orbicularis oris muscle. Maybe that, I shouldn't do that, but there it is again. And that's the round one around the mouth. Oris, mouth. Orbicularis oris. If you look on your list, that's somewhere further down there. From the orbicularis oculi. It's almost at the bottom. Third from the bottom. So then what we get to is the nasalis muscle. The nasalis muscle. Talk about muscle names. Look at that name. That's a long friggin' name. It's not on the test, don't worry about it. But levator labii superioris aliquinasa. It's the longest muscle name. So after that, you don't have to worry about it anymore. But we also know it has the Elvis muscle because it's actually a small little muscle here with this long name. But it's interesting how it's built. The name is built. You see this word levator. We have another muscle that we have levator. That levator means lifting something up, elevating, right? So you think of those things when it comes to mind. What does that could mean? Labii means lip. 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 Here, the lip. Superioris. And see, this lifts up the lip. Superioris means above something. And so it's building up that name. Aliqui means wing. That one I put here because it's not that common. But again, we don't worry about that name. But we have other names that have those words in them. Nasalis muscle, that's on the list. That one's easy, right? Where will that be? By the nose, I think. So that's another thing. If something makes sense in this anatomy, physio stuff, go with the making sense flow. If it doesn't make sense in the head, then you need to study what doesn't make sense so you understand, or at least that's how I learn. Like, otherwise it's so much stuff to study, you know. So I filter it. If it already makes sense, I just have to remember, that one makes sense, so I can remember it that way. So nasalis, don't think too deep. It's by the nose. Then we got a few muscles around the mouth. And we got two that lift up the lips at the corner of the mouth, and then one that bring it down, and then a couple that go onto the side. And so the first one there on the list is the levator labii superioris muscle. Actually, let's go first to the Zygomaticus muscle. The Zygomaticus muscle is one that goes to the zygomatic bone that we just studied, the cheekbone. So there's one muscle here, then it goes right to the cheekbone. So that's going to be the zygomatic muscle. So another way, when you do the test, you have to basically just name different muscles. But one way of really understanding the muscle world is by understanding where they're attached. And so when you see the Zygomaticus muscle, you know it's attached to the cheekbone. When you look at this model, you see there's one muscle that's attached to the cheekbone going to the mouth. That's going to be that muscle. And so that's one way that I look at muscles. In my clinic, I do more with my touch. I feel where do they start in the bone, and then I understand which muscles do I need to work or not work.
Where is the Zygomaticus minor?
It's right next to it. I prefer not to get that question in this one. Because I don't never know on the model. I never know on the model. Yeah, here, it's right next to it.
Okay, cool, that's what I thought.
Yeah, it's just a baby. So we can talk about the minor major. Actually, a lot of, I don't separate them often because except for one in the arm, there's a few that don't do the same thing, but very often when you have two muscles that are right next to each other, one is smaller and bigger, the other they call them minor and major. And so we're very often, and it's good you bring it up because I just combine them very often. They're just a small one and a big one next to each other. We have a few of them like that. We do have a few that do different functions that just have the major minor name, but we'll separate those when we get to those. I know, this is some interesting stuff. So that muscle, the zygomaticus, goes from the zygomatic bone to the corner of the mouth. And then we have the levator labii superioris muscle. And here we got the zygomaticus. See, this picture is nice. We've got both here. See that? Major, minor. And then right next to it, we can really only see it on here. It goes underneath it into the lip. It's the levator labii superioris. So this is a hard one to see here. It's sort of like underneath on the side here. It goes into the lip and lifts the lip up. And so another thing with this anatomy stuff, like this is a really hard muscle to see. Most likely it won't bring it on the test. All right, so I'm trying to go with what's visible, what's not confusing. Not necessarily easy, but if it's like, wow, this is really a tough one, you can ask me, we can talk about it more, but also sort of have the understanding it's probably not on the test if it's so complicated. All right, and if it is, and we have, then we talk about it, we're worried about that way at that point. But I don't want you to be too freaking out about these, and because in that it's somewhat ambiguous. It's not quite that clear sometimes. Everybody's a little bit different. And so we got to account for that. It freaked me out when I went through it, so that's why I want to be gentle about it. So if you have a little problem with that, just speak to me and we figure it out, I'm sure. All right, so then we have these two muscles on top, and we have two muscles on the bottom. So we have one that is in the angle of the mouth, the corner that goes down, and we call that the depressor, now not levator, but depressor, anguli, instead of zygomaticus. We just have anguli here. Anguli means corner. Oris means mouth. And so that muscle is on the side of the mouth, pulling the corner of the mouth down. And then next to that in the front, a little bit right next to it, here we got one that's going to be called depressor labii inferioris muscle, right here next to it. And so that's right here next to it. One and then the next to it here, right side. So two on the bottom and two on the top that work with the mouth corner. Well, you got to be able to smile and frown and pout and do all that kind of weird emotions with the mouth. We need all these muscles to do that. Facial muscles are here to create facial expressions. And facial expressions are here to express a lot of it express our emotions from the inside out. And so when you look at the chapters in a book, the way I structured that chapter is by facial expressions. And so that's why these muscles become important. And the mouth is, of course, important to do that. We also have two muscles on the side of the mouth that pull the corner of the mouth backwards. And one of them is the deep one right in here. It's the buccinator. And that muscle creates a dimple. If we see a dimple, that's what that muscle does. It's a very thick muscle in infants because it creates the mouth basically being a hose that can suckle when we need the milk. And so that's, if you have your own baby, you feel that inside of the mouth. When I remember, I felt that, I'm going like, holy cow, that cheek is thick on a baby. I don't know if you ever experienced that, if you have kids. But that would be the buccinator. That's very well developed in the infants. And then the last one on that is a little sliver muscle on top of the buccinator that goes backwards from the corner and tightens the lip a little bit this way. And that's the risorius muscle right here. Risorius. And then the last ones from there we have are the ones that chew, help us chewing. And we have 4 of them all together. We mentioned 2 of them here in the lab portion. And then one of them is, let me see, I think this picture is better here. One of them is going from the temporal bone, down to what's going to be the coronoid process. So it goes down from here downward and closes the jaw. Closes the jaw in this sort of angle that way. And then the other one, what was that? Oh boy, it's over here. And then the other muscle is attached to the zygomatic and goes down to the ramus of the mandible and closes the jaw this way. So we have these 2 muscles, the maxilar and the temporalis, that do that chewing motion. We have 2 more on the inside of the mouth. We have one that's like the same type on the inside of the mandible that does the same. So the mandible bone ends up being like a sandwich with 2 muscles on each side. It took me a long time to understand that, but you can actually help somebody with TMJ problems to really massage these muscles and also take a finger, go inside and massage the inside. If you know, you have to have a little technique on that. But so that's basically what those are about. Any questions to that? So now we're looking at bones again, not muscles. Now we're leaving the skull and we're going down the spine. And then we're going to talk a little bit about the ribs and a little bit about the tailbone too. That makes more or less up the axial skeleton, the midline of the central line of our body. If we're looking at the spine, the backbone, we have vertebrae. If you look on your desk, you have these vertebrae here. These things, these are the vertebrae. So there's a lot of different vertebrae. There's 24, there is 7 on top that make up a neck. They're the smallest ones. These small ones are the ones in the neck. And then we got 12 in the middle section, that's where the ribs attach. So everywhere where a rib goes in, that's the middle section. That's called the thoracic spine. The top one, the neck part, is called the cervical spine. So the thoracic are the ones that are a little bit bigger. The ones that have a long thing in the back go down. That's the middle section, thoracic vertebrae. And then down below, we have a low back. Right here. And those are the biggest one of the vertebrae. And they're like that. There are 5 of those. They call them the lumbar vertebrae. The lumbar. They're curved. If you look from the side, they're curved. So they have different names to the curve. We'll do that a little bit in lecture, but we're not going to be too heavy on that in lab. So what we're going to do now, we're going to look at one of these vertebrae as a generic vertebra. So I usually use the low back one, the lumbar one. And we look at it like that. So we lay it flat. So the big piece is in the front, the bottom here. This is actually the front piece. If you see here, the brown big piece is in the front. In the back, we got this pokey stuff. So if you touch your neck, you feel these pokey things. Did you ever think what these pokey things were? I never thought about it until I learned about it. But it's probably good. It draws all these anxiety, right? So, the big pokey thing is that thing sticking up. That's here in the back. Alright? So when you look at your list, you have some terminology over here. We have on the vertebra, it says there. It says, this is the vertebra. It says body. The big thing, usually, something is the biggest part of a bone. Very often we call that a body. The body of the vertebra. So on your model, I don't know why this is all twisted. There we go. On your model, that's that big thing. So if you go back, well, no, we don't have to go back because it's right here. If you go back to that big spine overall that we were looking at a minute ago, it's all these big things in the back. In the front, sorry, not the back, the front, those are these bodies. All right? So So it's like we're upright and then we're laying flat again. So we're laying flat again. From the body, we got these two big pillars that come up. Actually, let me go backwards a little bit. Let me explain something. Here you got the brain. And the brain goes down, and then we go down here, we got a spinal cord. And it's kind of like an extension of the brain, the spinal cord. And it then talks to the body. Because what the brain does, the brain controls every function in the body. So every movement we do has to be coming from up here and talk to the body and somehow has to be able to communicate. And it's not telepathic. We're going to do that next century. For now, we're still left with electricity. And we communicate from the brain to all the muscles in the body through the spinal cord and then through these nerves that come out on the side here. They go to all the muscles in the body and they talk to those muscles. And so the problem, as I said before, is the brain is very moldable and very gentle and very gel-like. So is the spinal cord. A little bit firmer, but not as firm as we want it to be. And so it really needs to be protected from the outside influences so it doesn't get compressed. Particularly compressed, physically compressed. And so it travels down in a enclosed hole of bone, sort of a channel of bone. And that channel is made up by all these vertebrae stacked on top of one another. These donut-shaped things. And so that's what we're looking at. So that's why we're going to create this hole in here. So we have the spinal cord be able to go up and down here. Okay? Yes?
What is this red thing?
That's a pathology.
Oh, okay.
So we can go right there real quick. Absolutely. So if you look at this big meat, I call it the meat rod from a clinical perspective, because very often when I feel these people, it's like, this is inflamed feeling. And I touched this stuff in the back. They lay down. And it's like, it's a lot of muscles, a lot of bones, or bones underneath, then ligaments, then muscles moving all that around, all that together. And in between the two bones, or any two bones, we got a disc, a little pillow. So that's like a type of cartilage like Tupperware. Like fairly firm and like cartilagey, but somewhat soft. It's attached to each bone. And on the inside it has a gel. And the gel moves around. And so sometimes when you sit for a long, long time, and you stand up, it goes like, oh my God, that hurt. Like a shot in the back. That's when that movement of the gel happens and some of these fibers get stretched because you've just been, in that position. In German, they call that the witch's shot, which is actually a medical term, which is kind of funny they use that as I gave it away. I had a textbook that actually had that term in it to show people. It's like, it's really a term, When I don't have one of those. Give me yours. Where's mine? Mine is not a pathology bone. So if you have these, thank you. If you have these pillows in between these two bones, so these strong shells that connect from bone to bone, and this shell on the inside, you can visualize it like fiberglass. Have you ever seen fiberglass meshwork? It's very strong stuff that's like fiberglass going from bone to bone. And the inside is that gel, and so you can move around a little bit. But sometimes that thing breaks. It's a disc herniation. They call that a herniated disc. Or, that's a very common pathology. And when that thing breaks, that shell, the inside gel can squeeze out and can put pressure on that nerve. And that's where we call that sort of, for example, classic sciatica. The bone, the nerve is compressed. Classically, that's when they want surgery to take that away. And so it doesn't compress anymore. Very often when we have really strong back pain, it's that the outside shell is irritated. It doesn't have to be squeezing out. So that's one of those things where classically, so that's what that red thing is, that squeezing out thing, right? It's a pathology. And classically, that's where they do surgery. And we have to, that's where we have to be a little careful because a lot of times the body actually reabsorbs those things by themselves if we create proper movement. But that's why that is there. It's a very, very common pathology. So let's go back to that. So we got the body in the middle, the front, and then in the back, the thing we can touch, we call that the spinous process. And then anything else here that makes, what we are interested in here, making up this space in between that the cord can go up and down. And so from the body we have these two pillars coming up, we call them the pedicles. So if you look at the body here, you got these two things coming up, those are the pedicles. And then on the side we got these processes sticking out, things sticking out of bones. We often call them process. Transverse process. Often something sticking out of the bone like that, you're thinking muscle attachment. Because why else would it come out do that? Alright? You always think of why would that be the case. And then from the transverse process reaching backwards to the spinous process, we have a little bar of bone, depending on which section is bigger or smaller, and we call that the lamina. The lamina. So the pedicle, transverse, spinous makes up that vertebral arch, we call that. That hole, that space, that then the nerve can go in and up and down. So that's that. That's kind of cool stuff. I think that's really cool stuff. But I'm a bit of a nerd about that. Then most vertebrae in the whole spine are going to be having all those features. A few more and less. We talk about that in lecture. You know, this bone is smaller than this bone. We have a few features that we can distinguish which section that these come from. But two of them look a little different. And they are the ones on the top. And so on top we have one vertebra that's a ring. That's simply a ring-looking thing. Doesn't have a body. It's missing a body. And that thing is called the atlas. And that's the top vertebra. If you look at the head, you lift up a head, that first vertebra is that ring. It's known as the atlas. It's kind of like Greek mythology. The atlas holds up the world. So the world is a head. So that's where that term comes from. And then the second vertebra, what's interesting about that thing is, I said the first don't have a body. The second has an extra thing. It's got this thing sticking up in the middle. Right here. It's called a dens. Dens means tooth. Like a tooth sticking up. And that tooth sticks up through that ring, through that first vertebra, and makes sort of an axis with it. So it sticks up here, and then the first vertebra can rotate very easily around it. So it's very interesting because that joint here, that mechanism of having that, makes us be able to say no. Makes us be able to rotate because of that thing sticking up, that dent. If we wouldn't have that, we would be yes people. We couldn't say no. So that's, remember that, right? Anyway. But that's actually what happens. That's 50% of the rotation happens right here. If we really look at it, okay? What else we need to know about that? That's pretty good. I mean, it's interesting. Evolutionarily, most likely, this used to be the body of this, and then it got separated. But that's, evolution, in the question. From there, then, where we go is we go to the other side of the spine, not the top. Now we go to the bottom. We go to the sacrum, and the sacrum is a few fused vertebrae together. So it's your sit bone. So it's like, where you're sitting on. Although actually, no, it's not really your sit bone because the sit bone is these. So actually, you should be sitting on these, like sitting up straight. But most of us sit on the sacrum because we're kind of slouching. So we're just kind of sitting on that thing. But it's that bottom part where the spine comes down and then it has to figure out how to go from here, transverse the forces over to the hip, the pelvis, and then go to the legs down in here. So that's sort of what that bone does. It's sort of an in-between bone. It's fused vertebrae. And so you can sort of see that when you see like that's a vertebra, that's a vertebra, that's a vertebra. You see that? They're fused together and then they make it more solid. Some people have one of them that's still fused, not fused. It's a lumbarization. The low back spine is called the lumbar spine. So they call that. Those people have more motion in there. They have a little bit more back pain generally. But those here, see these lines here in the front? So you look from the front. You see these lines here. These used to be those discs that we had that herniation with. They're fused. So we call them the transverse lines or transverse regions. So that's the landmark I want you to know from the front. The landmark from the back, if you go to the back, that I want you to know is when you look at these bumps, they're like the spinous processes here. They're just fused. They're like rigid. We call that the median sacral crest. And then from there we can move right into the rib cage. I know I'm going to move it a little bit because I'm losing time here. It's a little slow today. I'm always slow. Just chatting. Oh. So the sacrum. Must that make sense what I said to the sacrum? Okay, cool. Then we're going to do more of the sacrum when we do about the lower next week, appendicular skeleton. So when we then move to the ribs, the rib cage, the thoracic spine, is all the vertebrae that are attaching, ribs are attached to. We want to first maybe pay our attention to the chest plate in the front, because the ribs go from the back to the front. And then they attach in the front. They got these cartilages in. So when you look at the breastbone, the front bone, is known as the sternum. Sternum. There's a few parts to it. The top part is known as the manubrium. And then if you go down, you feel a little bump here. That's the sternal angle. So that's actually a little joint. And then below we have a bigger portion. So it's kind of two bones. They're just pretty fused. And the lower portion is known as the body of the sternum. The big part. Again, something big, and if you see body, you guess it's the biggest part of the bone, most likely. And then below there, on the bottom, we have this little thing. It looks like a diamond shaped. It's like cartilage sheet. It's also bony, but it's both a little bit. It's very, very sharp. And it's known as the Sphenoid Process. It's a beautiful word, Sphenoid Process. We got the diaphragm attached to it. The diaphragm comes from back, around, below. There it attaches to the Sphenoid Process, and then it moves downward, and that enhances the volume of the lungs so we can breathe. So it's a very powerful muscle, the diaphragm. But if that bone here breaks, like if somebody does the Heimlich maneuver, when we choke too high up and it breaks back, it can pull back and pierce the liver. So it's a very interesting bone. It's very powerful. It's a very powerful bone. Sphenoid process. All right, so that's the breastbone. And then when we look at the ribs, we have 12 ribs. We got 7 that they call them true. Then we got a few they call false. Then we got free flow. And always, that terminology always confuses me. Because why the heck? What's different between the one? And so what is different between the true and the false rib is the fact that the true ribs have a cartilage that feeds directly into the breastbone. Do you see that? Goes directly from here, it goes into the breastbone. But then the next one, it goes not into the breast, it goes into that cartilage. And they call those false ribs. So the true ribs are the ones where they're attached directly to the sternum. The false ribs connect indirectly to the sternum. I know, little small detail. Clinically, I don't know. Well, don't have to worry about that right now. Then we got 2 ribs in the bottom. They are free flowing. They don't attach to the breastbone at all. So if you like giving massage, you make sure you don't poke from the side too hard down here. That could be, or that, you know, or if you really want to have a narrow waist, that's the one that people take out. Don't do that. But those are those ones. The free floating ones. And then to finish up, we're looking at one rib itself. The ribs go from the front to the back. And then the back, they attach to the bone, the vertebrae. And they attach to the transverse process of the vertebra and the body of the vertebra. And so they got a few bumps. Bumps are muscle attachments or joint-making things. And when you look at the bumps here on these ribs, you have one right at the end. They call that the head. Like a head. Very often, resemblance. And then you got a narrowing. It's hard to see here, but that's a little narrower. And that's called that the neck. Neck of the rib. Something narrower is neck, like in the head. Here, in the head, the neck. And then they don't call the next bump the shoulder. They could call that the shoulder. That would be good. But they call that the tubercle. And a tubercle is one of those terms you want to know that usually makes a joint, or actually more often there's a muscle attached to it, the tubercle. Like we got tubercles here in the arm that we'll talk about.
Where's that part?
Huh?
Where's that bone?
That's the rib.
Oh.
That's one of those.
Oh, okay, in the back.
Yeah. Thank you for asking because I assumed, sorry. Yeah, that's a rib. And here we go. And when we look at the rib, we look at the end mostly that goes into the vertebrae. And that's where these bumps come up. And the head attaches to the front. Like if you look here, the rib comes around and attaches to the front, the body. That's the head. And then on the side, you can see how the rib attaches a little bit to the transverse process, the side of the body, at the vertebra. And that's this part here. That's the tubercle here. Okay? So, anatomy people, they always have to give everything names. So that's one of those things,